I now have the pleasure of introducing John Vanderhoof. John was in my role as the Chief Medical Officer and Vice President for Global Clinical Medical Affairs prior to my taking on this role, and he actually recruited me to replace him. But he's been kind enough to continue in a role where he provides us with consultation and advice and remains an integral part of our company, who's very important. He also serves somewhat in a capacity as the doctor for Europe, and he spends more time in Latin America than he spends in Omaha, which is his home, because he loves it here. So probably all of you have had John visit you in your countries. John is also spends a week a month at the Harvard hospitals, where he's engaged in research and other activities, teaching and training and seeing patients. And he still runs a clinical practice in South Dakota, so where he flies his plane to see patients. Now, all of that's great, and John's had remarkable academic achievements through his life. But John's now celebrating a new event. At the age of 67, he has been health cleared to continue flying his airplane as a pilot. That was a really important thing he told me this morning. And he also passed his pediatric gastroenterology boards again, so which surprised all of us. But on that note, I want to welcome John and thank him for coming back down to Latin America. It doesn't take very much to get John to fly to Latin America. You say, hey, John, you want to go to Mexico or somewhere in Latin America? He goes, oh, yeah, I'd like that. So anyway, he's going to talk to you a little bit today about current perspectives in cow's milk protein allergy. Welcome, John.
Well, Colin, thank you. I only wish my mother were alive so she could have heard your introduction. You know, so it was very nice. And indeed, it is a pleasure to be back in Latin America and to see many old friends, and also to talk about something that I find very interesting. I put this together, and some of you probably heard me talk about this before, and a lot of it will be repetitive. I try to give you information that is sort of not Mead Johnson biased, and also information that will complement what Deolinda and what Professor Barney Kanani will tell you. So although I will allude to these things somewhat briefly, I think that's not the purpose of my talk here today, which is really more of a clinical talk about how to take care of babies with GI allergy or children with GI allergy. I still do that a lot in my practice, and I see these diseases every day, and I still scratch my head on how to diagnose them and with some how to treat them, as I'm sure you do. And so let me walk you through the clinical spectrum of gastrointestinal diseases in pediatrics. And I gave this talk for Boston Children's in Dubai, in Dubai in the Middle East. So I had to disclose that I was working part-time for Mead Johnson. And I also serve on the advisory board of another little company. And as Colin said, I do many things. I have so many conflicts that I don't think I could even list them all. But what I'm going to tell you today is pretty straightforward clinical medicine. So we start with intolerance and allergy. Everybody knows that sometimes you get sick when you eat a food, and we call that intolerance. And if it happens to be something that occurs through the immune system, we call that an allergy. And years ago, we used to say that allergy was when you made IgE antibodies, and if you didn't have IgE antibodies, that was intolerance, and we didn't know why that was. And now we've found out that, in fact, there are a lot of allergies that are probably T-cell mediated that do not give you measurable IgE antibodies in the blood, although there may be some tissue-bound IgE antibodies that are involved in the process. So we refer to that as non-IgE allergy, and it is a big part of GI allergy. An IgE-mediated allergy is I always like to say, the kind of allergy that anybody can diagnose, because you eat something and you get sick very quickly, and you take the offending substance away and you get well very quickly, and the symptoms that you develop are often very dramatic. Non-IgE disorders, they're very difficult. The symptoms come on slowly, they resolve slowly, they're basically a result of inflammation in the gastrointestinal tract, and for this reason, the diagnosis is much more difficult and requires a lot of clinical thinking. IgE-mediated disease is something we typically see in older children and adults. And they often have cutaneous and systemic manifestations such as respiratory problems, anaphylaxis, rashes, and so forth. It's often to foods other than cow milk, although cow milk is certainly a big offender, but we see it with peanuts. How do I say that? I always try to say cacahuate. Yeah, it's one of the only Spanish words I know, and I keep forgetting. Again, abrupt in onset and resolution, and I love to do intestinal biopsies, and it doesn't take much for me to find an excuse to biopsy somebody's bowel so I can look at the tissue under the microscope. And I can tell you that most of the time, these patients have normal biopsies, unlike the non-IgE mediated disease, which are usually abnormal. So the most common age for us to see food allergy is babies, and it's usually cow milk. And if you look into the literature, it usually says that somewhere between 2 and 7% of infants are cow milk allergic. Most of these data are based on screening with IgE antibodies and looking for IgE type disease. Since we can't diagnose nearly as accurately non-IgE disease, I don't think we have any idea what the actual incidence of cow milk allergy is. So we could argue all day. All I can say is I think it's more common than most people think. The most common clinical presentation that we as pediatric gastroenterologists see is allergic enterocolitis or food protein-induced enterocolitis syndrome, FPIES, in infants. And I will have to tell you that at least in the United States, eosinophilic esophagitis is becoming a very close second because we're seeing this disease very, very commonly as well. Food protein-induced enterocolitis is something that we typically see around 1 to 2 months of age, predominantly with gastrointestinal symptoms. These children can have almost any kind of a GI symptom, which makes them very difficult to diagnose in many cases. Typically, the symptoms they have are the result of inflammation in the bowel. And for this reason, they typically have abnormal biopsies somewhere. But the lesions are patchy, and you have to take multiple biopsies from multiple different places if you want to try to make the diagnosis histologically. It's insidious in onset and resolution because, as I said before, the symptoms are a result of inflammation. If you are allergic to cow's milk and you ingest cow's milk, the antigen has to interact with the immune system and cause an inflammatory lesion. And that inflammatory lesion will result in mucosal injury or inflammatory reactions around the enteric nervous system. And wherever that inflammation is, that will cause symptoms. So it may take several days or even weeks for those symptoms to develop. It's just very much like what happens when you challenge someone with gluten who has celiac disease. It may take a long time for that lesion to show up and for those patients to get sick. As a non-IgE allergy, this is what we see. And that is why it is so difficult to make this diagnosis by a double-blind, placebo-controlled food challenge. As I mentioned, FPIES is usually a non-IgE allergy, although occasionally we will see positive IgE allergy testing in these patients. The symptoms they have are pretty much reflective of where the inflammation is located in the gut. For example, patients with predominantly colitis will have bloody stools. If you have more inflammation more proximally, you may have more diarrhea. Small bowel disease is often associated with vomiting because the patients will vomit because their stomach's empty slower. And it may look a lot like gastroesophageal reflux, but the mechanism is very different because it's secondary to delayed gastric emptying rather than lower esophageal sphincter intermittent relaxation. Irritability or crying or colicky-like symptoms are very commonly associated with cow milk protein allergy. This is an easy diagnosis to make if they have all of the other symptoms. But if the only symptom they have is irritability, sometimes it's very difficult to tell this patient from a patient who has simple infantile colic or anxiety or some other related problem. And finally, because these patients have inflammation in their small bowel and they get pain whenever they eat, they respond to this by not eating, so they lose weight and develop failure to thrive. So you'll often see the weight start to fall off as the inflammatory process becomes more severe. So this leads us then to what are the value of the commonly utilized allergy tests in making the diagnosis of FPIES or most other gastrointestinal diseases. And I think there's some very important things on this slide. The first is that the value of these things is pretty much limited to IgE type disease. And if you have a positive test, that means that the patient has been sensitized to a food. We get sensitized to a lot of foods that we don't react to. But it means that you can react to it. So it means that there is a possibility that you might be allergic to this food. If you have a negative test, it tells you that the patient cannot have an IgE reaction to the food because they don't have IgE antibodies. But it doesn't tell you that they cannot have non-IgE disease. So where do we actually use these? A lot of times in older children above age 2 or 3 with eosinophilic esophagitis, sometimes we'll do testing, and if a patient has a very strong reaction, we may say, well, maybe they're, if it's a class 3 or class 4 or a big lesion, we might say, well, let's try eliminating that food, and sometimes that helps you. But oftentimes, what I'll see is patients with batteries of skin tests done, and the parents taking off 20 foods, and they're probably only allergic to 1 or 2 of them. And the other comment I can tell you is the allergy, the skin testing or the blood tests for milk allergy are not very good. And the kids are most always allergic to milk. So when you have one of these FPIs or an eosinophilic esophagitis, you take them off all cow milk protein, plus maybe something else based upon your test. But because the test is negative for milk, don't assume that milk is not a problem. So those of us who are gastroenterologists kind of have some things that we look for when we look endoscopically for allergic disease. And again, we're looking for subtle signs of inflammation. So loss of vascular pattern, prominent lymphoid follicles with some erythema around them, biopsies that show mononuclear cell infiltrate with some eosinophils. And then the question is always how many eosinophils and what does that mean? And nobody knows this. And in fact, I've got another project I'm doing now because I'm frustrated because nobody knows this. And I was met with a GI pathologist yesterday about this very thing. And we don't know how many eosinophils are normal. But I think there's more to this than counting eosinophils. You have to look for other signs of inflammation. You have to see what the eosinophils are doing. Are they just there, or are they degranulating? Are they actually doing something? In the small bowel, the signs are very simple. Mild villous atrophy with crypt hyperplasia, a mild increase in intraepithelial lymphocytes. We see these things in celiac disease. You can also see them in cow milk protein allergy. Allergic proctocolitis looks something like this, either with, okay, so you see more of these lymphoid nodules than you normally see in a baby with allergic colitis, and there's often inflammation that overlies them, as you can see in the second slide. And if you see this in a baby, so if you see these in a baby with the symptoms that I suggested, maybe this you need to think about allergic disease. But again, these are nonspecific findings. And the inflammatory lesions that you see, yes, there are a lot of eosinophils in here. You can see them. But there's also some increased mononuclear cells that you can see. And you can see some intraepithelial lymphocytes here. I don't know that they're actually increased in number, but you can see them. So it's a mixed inflammatory infiltrate. I even think I see a poly over here. If you look around, you'll find some of these cells actually will have 3 or 4 lobes and not just 2, and they're not really eosinophils. So you can see this kind of a picture as long as you can associate it with the clinical symptoms and the history that makes it all fit together, because these findings themselves are nonspecific. In the small bowel, you see the same sort of thing, a duodenal bulb with a lot of lymphoid hyperplasia, some overlying inflammatory changes, and sure enough, as reported in this particular paper, the patients get better when you put them on a strict cow milk protein-free diet. So a little bit about differential diagnosis. If you see these babies come in and they're crying all the time, and they may have some other associated symptoms, and they may not, it's often very difficult to decide whether or not this is an allergic baby or whether this baby has something else. And so so this is the short differential diagnosis, and this is what you're usually dealing with. And then we have a very long differential diagnosis, especially when you see babies like this who are failing to thrive or something. Your differential diagnosis gets much longer, and you have to think about many, many more things. Am I going too fast? I don't know. Can you follow? Everybody can understand? Good. Okay, we're all right. Good. Okay. So, so I like to say that most of the time when we see babies that cry, we think about, is this infantile colic, just a fussy baby whose immature nervous system seems to make him a bit more reactive? Or is this baby a baby with an allergic proctocolitis or food allergy? Or does this baby have gastroesophageal reflux? And I want to talk a little bit about gastroesophageal reflux because I'm on a campaign to make pediatricians not think about this anymore. We've spent way too much time thinking about gastroesophageal reflux, and we need to stop thinking about it so much. Reflux has been shown to occur when babies have intermittent physiologic relaxation of the lower esophageal sphincter. I think that this may well be a response to overfeeding, and that sphincter intermittently relaxes, and if the gastric pressure is too high, the baby will spit up. And normal babies do this, and some babies do it more than others. Unfortunately, in the United States, pediatricians have decided that this is abnormal, and they should treat it with a medicine or a formula or some kind of positioning thing, and rather than just letting it occur. The point I want to make here is that reflux is rarely a cause of irritability in a baby. It's just not something that happens frequently enough for you to think about it. And I'm very grateful to Colin, who gave me this slide, because I think this is a wonderful study that shows that if you take a bunch of crying babies and babies who spit up, and you put them on acid suppression with a very powerful proton pump inhibitor, you will find that there is no difference in response to the proton pump inhibitor or the placebo in either how much they cry or how much they spit up. And that would tell you, in this very nicely done study, that reflux is a very, very uncommon cause of irritability. Now, what's different about these babies between the placebo group and the treatment group is the treatment group gets more infections. Why does it get more infections? Because you've taken away gastric acid, which is our main mechanism of defending us against infections in the gut and respiratory infections. So we got to stop using these things, folks, in fussy babies. And I think we're making some progress, but we still see it happen way too often. So a lot of these babies that are crying and irritable turn out to have cow milk protein allergy. How do these babies differ from infantile colic babies? They cry most of the day. They don't feed very well. And they don't feed very well because when you feed them, the food enters the small bowel. There's inflammation in the small bowel. You start contracting the small bowel, and that causes pain because there's nerve irritation related to the inflammation. And then finally, there's low-grade malabsorption, so some of the malabsorbed carbohydrates get down into the lower small bowel, and they get fermented, and there's gas production, the bowel expands, and the patients get uncomfortable and they cry. They're typically not distracted by feeding. A colicky baby, if you take him for a ride in a car, you know, and the car bounces as he goes down the street, he stops crying, or you pick him up and you go, shh, 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 like, you know, pediatricians taught me this, and the baby stops crying. A true cow milk allergy baby doesn't stop crying because he's not just irritable, he's sick, it hurts, and that's why he's crying. These babies will often feed poorly because when they eat, they hurt, and so they don't eat, and then they start failing to thrive. They may have vomiting because they have delayed gastric emptying, or they may have loose stools because they have inflammation in their lower gut. One of the things that I learned in many years of practicing pediatric gastroenterology is that people with inflammation can not only get diarrhea, they can also get constipated. And you'll see babies like this who are actually constipated. And this is a response to the effect of inflammatory changes on the enteric nervous system. And there are numerous signs other conditions in which this has been well described. So I want to show you a case. And this was a 1-year-old baby who saw a pediatric gastroenterologist at a very good children's hospital in the United States, Denver Children's, I'll tell you where it was. And the pediatric gastroenterologist saw this baby for vomiting and irritability. And he did a biopsy of the small bowel and colon and said there were some inflammatory lesions and that the baby was allergic to the formula and needed to go on a special formula. And so the mother decided that if this was really allergy, she should take the baby to an allergist. So he took the baby to an allergist in private practice, and the allergist did some allergy tests and said, your baby's not allergic to anything, because the allergy tests were negative. So she then took the baby to yet another pediatric gastroenterologist who said, said, my baby's not allergic, the allergist told me, so what's wrong with the baby? Why does it cry all the time? Why does it spit up? So, well, this is reflux. So what we do for reflux, if the baby starts to not gain weight very well, is we do a fundoplication and put in a gastrostomy and tube feed the baby. So they tube fed this baby, this poor baby, Enfamil, after they put in the gastrostomy, and the baby cried and was irritable for another 11 months or 10 months or whatever. And then they decided they needed to see yet another doctor, and so they got in their car and drove a long ways, and I saw them. And I heard the history, and I said, oh, this is cow milk protein allergy. I think you probably should have stuck with what the doctor at the Denver Children's Hospital told you. And so what we did is we went ahead and did a scope on this kid, and this is what we found. You can see, well, here's the gastrostomy tube, and here's all the nodularity that we saw in the duodenum, which is more than you would normally see. And in fact, if you biopsy between the lesions, you will see the inflammatory lesions that we discussed. And so when I took the scope out, I thought, gee whiz, you know, this kid has lumpy, bumpy skin all over his body. I wonder if this is atopic manifestations related to cow milk protein allergy. And so I took this picture with the endoscope, and because I thought it would make a nice slide. And sure enough, when we put this baby on a hypoallergenic formula, the rash went away, the crying went away. But of course, the baby still won't eat because the baby was tube fed during the time of life when it normally learns to eat. So now the parents are struggling to teach this baby how to eat again. And I just want to show you this case because I think it emphasizes the importance of not talking too much about gastroesophageal reflux in fussy babies. Don't miss an allergic baby, and don't ever do a fundoplication on an allergic baby. If you think they cried before you did the fundoplication, wait until after you do it. So how do you treat babies with allergies? Is you take away the allergens. I mean, we've done this for years. And this problem does occur in breastfed babies. And in breastfed babies, what we typically do is we put the mother on a strict hypoallergenic diet of some sort. I always just do milk because 75 to 85% of the time, milk is the problem. And following a more complex diet is really difficult. Even a milk-free diet is very difficult. Because if you're going to do this, you have to get absolutely all of the cow milk protein out of that mother's diet. You see what happens in a lactating mother's gut is it is increasingly permeable to antigens. And it's increasingly permeable to antigens so that the immune system can pick these little antigens up and transfer them to the mammary gland and pump them out. And it does this so the baby can sample little antigens and learn that these are food antigens and they're supposed to develop tolerance to them. And Roberto will be telling you all about tolerance here later and how very important it is. But sometimes, either because there's too much antigen or because the baby's too reactive, the baby will react to these things. So in order to get these out of the mother's milk, you've got to get rid of all of the antigens from that cow milk out of that mother's diet, because that GI tract, the immune system in that GI tract is looking for them. So, you know, they have to sit down and read labels. We have little handouts that we give to the mothers to help them do this. If the baby is formula fed, what we do is we put them on an extensively hydrolyzed formula. 95% of the time that works. We only use amino acid formulas if the babies don't respond to the extensively hydrolyzed formulas after 2 weeks of trial. I like amino acid formulas. I was one of the original describers of the use of amino acid formulas in allergy. You go back and look around in the 1997 literature. But these things are overused in pediatrics also. And I'm not going to tell you why, because I want Dr. Kanani to tell you that. And I think you'll be very interested in seeing the results. However, there are several formulas that you need to think about that are not lactose-free. I'm sorry, that are not hypoallergic. Lactose-free formulas are not hypoallergenic. Soy formulas are probably even more allergenic than cow milk formulas. And if you feed them early enough, babies will all get allergic to them too, just like they do to cow milk. And there's at least a 50% overlap. And probably the earlier you feed the soy, the more likely you are to see that. Goat milk. There's a 90% IgE cross-reactivity between goat and cow milk. If you're lucky enough to own a camel, it's only 10%. Actually, a horse is only 10%. I always used to joke and said, well, it's hard to find a camel. But when I gave this talk in Dubai, I found out that there were a lot of camels, and in fact, all the stores sold camel milk. So maybe you could use camel milk, but we have very good formulas for this now. These extensively hydrolyzed formulas are very good. Partially hydrolyzed formulas are not hypoallergenic. They're different. When you take a partially hydrolyzed formula, what you do is you take a protein, you throw in some enzymes, and it breaks up this big folded structure so that changes things, because there are some little proteins that you can react to that are results of the folds. But when you open it up, you expose all sorts of other different antigens. So it's like a soy formula. It's different. It's not hypoallergenic, but it's a different protein. And that's how you need to think about it. So in France, rice hydrolyzed formulas are becoming popular. And I should point out that the soy formulas that we have are also partially hydrolyzed, just like the rice formula is partially hydrolyzed. And people are selling these things now, even though they're nutritionally not as good as the soy ones. And sure enough, what we're now starting to see is rice protein allergy in France. How common is it? I suspect it's probably going to be as common as soy allergy once people start using this enough, because you're now starting to see more and more and more case reports of this phenomenon. So I don't think that rice hydrolyzed formulas are a very good answer for these kids either. So Roberto gave me this slide, and he and I gave a talk together in Chicago last week, and I noticed that he's got a newer slide, which he could maybe give me sometime. But it shows this trend continuing, more and more allergy, and there are tons of reports and tons of slides that will show you how much more common allergy is now than it used to be. And I think Dale Linda probably showed this slide, and I know Roberto may show it, and it's talks all about the hygiene hypothesis and how, you know, if you're around farm animals and you live and grow up in dirty places, you're very much less likely to get allergies. Allergy are diseases of people who live in clean environments, which is why you see them in Scandinavia, where it's too cold for bacteria to grow in Scandinavia, and the very northern parts or the very southern parts of the world, allergies are less common, and that you get closer to the equator and they become more common and so forth. And this hygiene hypothesis is evolving, and I think Roberto will tell you a little bit about the concept of how we're now not talking about infection so much as we're talking about early colonization and tolerance development. It's a little bit different in looking at these. And there are a whole series of studies that are based on the concept of using probiotics to prevent or treat allergies that are based on this whole idea of changing the early flora. And I'm sure that you've seen these before, and you'll probably see them again, but these are the Isolari data that simply show that if you treat a baby with atopic dermatitis with Lactobacillus GG in addition to his formula, it makes them get better. And there are several studies out of their group and a few studies from other groups like that show this. And in fact, it works for allergic colitis. This is the Baldessari data that show that the blood goes away more quickly in babies with allergic colitis if you give them LGG. So it not only works in the skin, it works in the gut. How does this happen? Well, this is kind of an interesting little set of data, and if you'd have asked me this 10 years ago, I'd have told you that LGG has a very interesting way of interacting with the immune system and changing how lymphocytes develop. And then I found out that, if this works the way it's supposed to, Lactobacillus GG, when given to babies, changes the whole spectrum of flora in the gut and dramatically increases the number of bifidobacteria and lactobacilli in the gut, so it very much functions like a prebiotic. And then there's this study, which basically shows that if you put a prebiotic in an infant formula, you can have a reduction in atopic dermatitis, very comparable to the same level you would get in breastfeeding. So there may be more than one thing going on here. It may be the effect of numerous different organisms that are produced by giving LGG, or it may be the LGG itself, or it may be a prebiotic effect. And I think Dr. Kanani is going to tell you that it may well have something that these bacteria are making in response to changes in the gut flora that might be causing this effect. We don't know, but it's very, very interesting, and we do know that it works. And Roberto will tell you a lot about this whole concept of tolerance induction, this being the new paradigm of allergy treatment, how we're working to get away from the concept of allergen avoidance and now to inducing tolerance. And what we're not talking about is oral desensitization. And all of you folks that are allergists, excuse me if I try to explain something I don't understand. But I think desensitization is more a production of blocking antibodies so that the IgE antibodies can't react with the antigens. It doesn't read, is that right? Did what I said? Something like that? Yeah. And so we're not retraining the immune system, whereas tolerance induction is different, and we're actually retraining the immune system. These kids get better they get better by the time they're 1 or 2 years old because they develop tolerance. Now, in addition to this disease, because allergy is becoming so much more common, we are starting to see a whole big new spectrum of allergic disease that we didn't used to see. And the first one I want to mention is eosinophilic esophagitis. So I will tell you a little story about this disease, and it has to do with how old I am. I realized today, or this week, that I have been practicing pediatric gastroenterology now for 40 years. So as I started my fellowship in 1974, and this is 2014. And I trained at UCLA, which was the birthplace of pediatric endoscopy and biopsies. And believe you me, I have biopsied hundreds and hundreds and hundreds of guts and esophaguses. And I can tell you that this disease was not there 20 years ago. I mean, it was not there because I looked for it and I never saw it. And now we see it all the time. This disease, the first I could remember it is in about 1995 or 6, when I was chairman of pediatrics at Creighton University in Omaha. There was a very famous esophageal surgeon there named Tom DeMeester. And Tom had built up this huge esophageal program, and they were finding eosinophilic esophagitis in adults. And they did not know what it was, but they found that if you treated it with corticosteroids, it got better. And shortly thereafter, a guy named Kevin Kelly, who at that time was at Hopkins, and now I think is in Philadelphia, was actually took these patients and fed them an amino acid formula. And the eosinophils went away, and Kevin proved that this was an allergic disease. And since that time, it's taken us 20 years to drag our adult gastroenterology colleagues around to making them understand that this is an allergic disease. But it is, not only in children, but also in adults. These patients present predominantly with dysphagia, and they do have heartburn, but they really have a lot of trouble swallowing. Because while we biopsy their esophagus and we find eosinophils in the mucosa, these eosinophils go all the way through the esophagus in this disease, and they degranulate around the nerves, and they mess up the esophageal motility and create a motility disorder. They typically only respond partially, if at all, to proton pump inhibitors. And you think of them when they have dysphagia without a stricture. And I'm sure that some of you have seen these tremendous number of eosinophils. But here, the tip-off is you find them at multiple levels of the esophagus. And whenever I suspect an eosinophilic esophagitis or any kind of esophageal disease anymore, I take 3 or 4 biopsies about 3 centimeters above the lower esophageal sphincter, and then I move up to the more proximal esophagus, and I do the same thing. And I put them in 2 different bottles. And if the lower one looks a lot worse than the upper one, it's more than likely reflux, because eosinophils you can get with reflux too. But if they look the same, or the more proximal one is worse, it's usually eosinophilic esophagitis. And that's the easiest way to tell them apart. Don't get into counting eosinophils, because it's a patchy lesion and they vary too much one from another. And this is what they look like. You see a lot of, this is an old picture, but they have these little furrowing lesions with little white plaques with eosinophilic abscesses in them. Back in 2001, we described a group of kids that had eosinophilic esophagitis, and we put them on a strict milk-free diet, and they got better, and their biopsies got better. And I only sent this out as an abstract, and I never wrote it up. And then a couple of years later, people described how dietary treatment works in eosinophilic esophagitis. And once again, and I've learned this lesson over and over in my life. I learned it with short bowel colitis from Judy Sondheimer. If I see something, now I write it up before somebody else does, because we were onto this 2 years before everybody else was. So how do you treat this? You treat it with an elimination diet. And there are different ways to do this. And some people do skin testing and remove milk plus the high reactors. And some people some people exclude the common food allergens. What I do is I put them on a very strict milk-free diet. And that fixes about 70% of them. And then I worry about the other 30% when that doesn't work. We have some drugs we can use, and they're predominantly steroids, either fluticasone or budesonide. There are different ways that you can mix them, but the idea is to mix them in such a way that when you swallow them, they coat the esophagus. And most of us in pediatric GI think you should try diet first. And if that doesn't work, then you should do this, because they get Candida esophagitis and they're difficult to administer and so forth. It's now become common to put these patients on PPIs, proton pump inhibitors, and I think all of us now realize that there are certain patients with this that do respond to that to varying degrees, and even the adults are now calling these PPI-responsive eosinophilic esophagitis. But histologically, they look exactly the same as the other ones. How can you tell if the patient's better? We don't have any good tests for this. The only thing you can do is go back in and do a ton of biopsies or follow them symptomatically. And if intermittent food obstruction is the only symptom they have, sometimes that's kind of difficult. So this disease, we haven't quite learned how to treat yet, but that's what we're doing with it now. Chronic constipation is another disease that can be caused by cow milk protein allergy. Although this is much more controversial, especially in the United States, there are a lot of people who don't believe in this. The Italians have described it very well. They get constipated. They're usually toddlers or a bit older. You take them off cow milk, they get better, and you put them back on cow milk, and the constipation comes back. If you go back into, and here's another example, we abstracted this, and this was back in 1999, you go back into the history of these kids, and there's often problems during infancy. Either the baby was fussy and irritable, was put on a special formula, threw up all the time. Go back in the history and find out what they were like as a baby. The next thing I want to mention is protein hydrolysate intolerance. And these are those 3 to 5% of kids who get sick when they drink a protein hydrolysate formula and get better on an amino acid formula. They do exist, but they're not very common. The symptoms they get are exactly the same as the other babies, and the biopsies look exactly the same, with focal eosinophilia or some mild proctitis. So you cannot tell these babies from the other babies histologically. All you can do is put them on the extensively hydrolyzed formula and wait 2 weeks and see if they get better. And now we're starting to see a lot of babies with multiple food protein intolerance. And these are babies that often start out as babies who don't respond to the extensively hydrolyzed formulas, and then go on to develop several different food allergies, so that you will have a few foods that the baby can eat and not very many more than that. And they're very difficult to manage, and by the time they get to about 5 years of age, they outgrow it. The allergy testing is usually not helpful because they're predominantly non-IgE allergies, and they usually don't react. And the only way to treat them is to introduce a food and wait 2 weeks, and then introduce another food and wait 2 weeks. And they take a lot of work, and they're a lot of struggle. And I promise you, you do not want 10 of these in your practice, because that will take up all your time. They're very difficult. And then a couple of other things. This paper describing allergic proctocolitis in children. And if you look at here, the age of these babies, or age of these children, 6 months, 15 months, whatever, or age, age of presentation, 11 years, 10 years, 14 years. So these are 10-year-old kids who come to you with blood in the stool who actually have allergic proctocolitis. Now, I used to think this happened only in babies, but now we're starting to see it in older children. So it might make you wonder, does this happen in adults? And sure enough, allergic proctocolitis in adults has now been described. How often, how common is it? I don't know. But it's like Roberto's slide. The incidence of these things is going up, and we're starting to see new syndromes, and we're starting to see them at different ages than we did before. And here's the picture of the adults. And then there's this disease. And there's now a description of a bunch of patients who get sick when they eat gluten. And I always like to say there are 4 reasons that I know of why people get sick when they eat gluten. One is they have celiac disease. The second is because gluten, the way it's locked into the fiber in the wheat kernel, carries the starch further down into the bowel than rice starch or cornstarch or whatever. So there's more fermentation with wheat than with other carbohydrates. So there's an opportunity to ferment and get gas and so forth with wheat, even in a total physiologic state. So it can be physiologic. The third reason is that the patient's crazy. And I think this is most of them. And we see in the United States, half of us are on a gluten-free diet, and the other half of us are normal. And of the ones that are on a gluten-free diet, I think a few of them have celiac disease, a few of them may be fermenters, a lot of them are crazy, and then we have this group. And this has become non-celiac wheat sensitivity. And there are a couple of papers. Why does this stuff always come from Italy? I don't I'm very glad you're here. You could tell us. But these patients appear to have a group of symptoms that are both gastrointestinal and neurologic or psychiatric, and often multi-system inflammatory diseases that get better on a gluten-free diet. And I think if you put this all together, and especially if you look at some of the other things that go along with these patients, things like intraepithelial eosinophilic infiltration in the colonic mucosa, positive serum IgG antibodies, other evidence of immunologic activity, history of food allergies, and so forth. A lot of these data suggest that this may be a non-IgE mediated food allergy, which I think it probably is. How common is it? I don't know. It's just been described. We'll have to wait. How commonly do they have abnormal biopsies? People tell me they're abnormal. The abnormalities are slight but significant. So this is probably the next big thing that we're going to be seeing. So in conclusion, I think gastrointestinal allergy is probably underappreciated by everybody except me and Dr. Kanani, and that we continually have new syndromes that have been reported, like this constipation thing, the gluten intolerance, eosinophilic esophagitis, which is not so new anymore. And unfortunately, because these are non-IgE allergies, making the diagnosis requires us to be really good clinicians, to take a really careful history, to be very, very diligent about how we educate and train our parents and how we follow our patients and how we how we evaluate their response to therapy. So that's my quick walk through allergic disease of the GI tract, and I'd be very happy to do whatever Colin says at this point in time, which is what I normally do in life. So.